Imagine one day, any day, even today, you collapse without warning. Your chest tightens, your heartbeat becomes irregular, and you struggle to catch your breath. Fatigue sets in quickly, making it hard to get out of bed.
Swelling appears in your legs and ankles. You may feel dizzy or faint, and even small efforts leave you exhausted.
Doctors run tests, but find no clear cause at first. As your condition worsens, they discover your heart muscle is under attack from your own immune system.
The diagnosis is a rare and aggressive disease that can progress rapidly and is difficult to treat. Today, we are talking about a giant cell myocarditis.
Welcome to the deep dive. Today, we're plunging into a condition that, well, cardiologists sometimes call a true medical horror. Giant cell myocarditis. It's a rare, frankly terrifying disease where your own body's defenses mistake your heart for an enemy and launch an attack. Our mission is to really understand what makes it so devastating and the desperate fight to diagnose and treat it.
That's right. Giant cell myocarditis, or GCM, it's an incredibly aggressive illness, targets the heart muscle directly. And it's autoimmune, meaning the immune system, our shield against infections, gets fundamentally confused.
Confused and turns inward.
Exactly. It starts destroying healthy heart tissue instead. What really sets GCM apart and makes it so feared is just how fast it strikes and progresses. It's not like those heart problems that develop over years. This is sudden.
So take us inside this attack. How does the immune system actually, turn on the heart like that?
Well, it starts with immune cells, specifically T cells, moving into the heart muscle tissue. Now, normally they're meant to fight off invaders, viruses, bacteria.
By the good guys.
The good guys. But here they start attacking and killing the actual heart muscle cells. And a really unique feature of GCM, what gives it its name, is that some of these attacking immune cells actually fuse together.
Fuse together.
Yeah, they form these distinctive giant cells that pathologists specifically look for under the microscope. These giant cells, plus all the surrounding inflammation, cause massive damage. They replace healthy, pumping heart muscle with scar tissue.
And that scar tissue, it doesn't contract.
Not at all.
Yeah.
It just sits there. So the heart gets weaker, it pumps less efficiently, and it becomes prone to really dangerous electrical chaos.
One of the most, I think, unsettling things about GCM is who it tends to strike. We usually think of heart disease affecting older people, maybe with certain lifestyle risk factors, right?
Exactly. That's the typical picture. But GCM often hits young to middle-aged adults, frequently people under 50 who were completely healthy just weeks before.
Wow. So no warning signs.
Typically, no clear predictors. You don't usually see the high cholesterol, the long history of high blood pressure, or even the family history we associate with other heart conditions. It's just incredibly unpredictable.
Is there any idea what triggers it?
The exact trigger isn't fully known, honestly. We think it's some kind of abnormal, maybe overzealous immune response gone wrong. We do see a link, though, in about 20% of cases where patients already have other autoimmune conditions.
Like what?
Things like thyroid disease or lupus, Crohn's disease sometimes. It suggests there might be some underlying vulnerability in certain people's immune systems.
Okay, let's talk about the symptoms.
Yeah.
Because this is where it gets tricky, right? It starts this devastating journey, but often with signs that seem minor, easy to dismiss.
They really are, yeah. The early signs can be frustratingly vague. You might just feel this persistent fatigue, not just tired, but like profoundly exhausted.
Which makes sense if the heart isn't pumping oxygen well.
Precisely. The damaged heart just can't deliver enough oxygenated blood. Then you might notice shortness of breath, maybe just during activity at first, but pretty soon, even when you're resting or trying to lie down.
And swelling.
Yes, swelling in the legs and ankles is common as fluid starts to back up, and sometimes just a dull, kind of persistent ache or discomfort in the chest.
And because these can feel like so many other less serious things, maybe stress, the flu, just being run down, people might not rush to the doctor immediately.
Right, and that delay is part of the danger with GCM. Because while these symptoms seem mild, the immune attack inside is escalating rapidly. Within weeks, maybe just a few months, those vague symptoms become severe.
Now severe.
Patients start developing palpitations or serious irregular heartbeats, what we call arrhythmias. The inflammation is disrupting the heart's really delicate electrical system.
Okay.
We see life-threatening rhythms like ventricular tachycardia VT. That's a very fast, dangerous rhythm coming from the heart's lower chambers. It's common.
And that can cause fainting.
It can. VT can lead to feeling lightheaded or actually fainting. Syncope is the medical term, either from the electrical disruption itself or just poor blood flow getting to the brain. And the chest pain usually worsens too. All the while, internally, the heart muscle is being actively destroyed, scarred over.
And this quick destruction, that leads directly to heart failure.
Yes, and often what we call fulminant heart failure. That means rapid, catastrophic failure. It's not the slow decline you see with chronic heart disease.
How quickly are we talking?
It typically develops within, say, 8 to 12 weeks of those first vague symptoms appearing. You'll see severe shortness of breath even at rest. Patients feel like they're drowning because fluid fills their lungs.
Pulmonary edema?
Exactly. They often can't lie flat because of it. Extreme weakness sets in. This stage happens because the immune system has wiped out a huge chunk of the heart muscle, anywhere from 60 to 80% sometimes.
60 to 80%. That's devastating.
It is. It's replaced by useless scar tissue. The heart's pumping ability, what we measure as ejection fraction, drops drastically, often below 30%. Normal is over 50–55%.
So on top of the heart muscle just failing as a pump, you mentioned the electrical chaos.
Absolutely. The inflammation and the scarring, they turn the heart into, well, an electrical minefield. These damaged areas create abnormal pathways that mess up the normal electrical signals. That's what leads to those life-threatening arrhythmias.
Like the VT you mentioned.
Like VT, and sometimes even worse, ventricular fibrillation or VF, where the heart muscle just quivers uselessly instead of beating. Patients can also develop serious heart blocks, like AV block, where the signal between the upper and lower chambers gets interrupted, sometimes needing emergency pacemakers just to keep the heart going.
And tragically, sometimes the first sign is the worst possible one.
Yes. Sudden cardiac death is the first symptom in about 20% of GCM cases. It's horrifying. We've seen these devastating instances like a young, healthy man whose very first sign was a fatal arrhythmia, or someone treated for something completely unrelated like vomiting who then died suddenly from GCM.
And treating these arrhythmias must be incredibly difficult.
It's notoriously hard to control them because the underlying problem, the inflammation, the scarring, is constantly creating new electrical short circuits, you could say. Even implantable defibrillators, ICDs, they can shock the heart back to rhythm, but they don't stop the disease process itself.
Given how quickly GCM can escalate from these vague beginnings to a life-threatening crisis, and how easily those early signs are mistaken, I mean, diagnosing it must be a terrible challenge.
It really, really is. Doctors, especially cardiologists, fear missing GCM precisely because of this rapid progression. The symptoms mimic so many other conditions.
Like what?
Oh, everything from common viral infections, anxiety, other types of myocarditis which are less aggressive, different kinds of cardiomyopathy. Even sometimes it's misdiagnosed initially as a standard heart attack.
That overlap must cause huge delays.
It's a major reason. Studies have shown diagnosis delays can average over 9 months, and routine tests, things like EKGs, echocardiograms, the heart ultrasound, even cardiac MRIs, or blood tests for heart injury markers like troponin, they're helpful. They raise suspicion, but they aren't specific enough to say this is GCM.
Even an MRI, I thought that was pretty good at seeing inflammation.
It is, but the pattern of inflammation on MRI and GCM can look quite similar to other conditions, especially cardiac sarcoidosis, another inflammatory heart disease. So it points you in the right direction, maybe, but doesn't seal the deal.
So if those non-invasive tests aren't the definitive answer, what is? How do doctors know for sure?
The gold standard, the test we rely on to make that final diagnosis, is an endomyocardial biopsy, EMB.
Taking a piece of the heart muscle itself.
Exactly. It involves guiding a special catheter, usually through a vein in the neck or leg, up to the heart, typically the right ventricle. Tiny pincers take out a few small samples of the heart muscle.
And what do they look for in those samples?
Expert pathologists examine them under a microscope. They're looking for those telltale multinucleated giant cells we talked about, along with widespread inflammation and evidence of heart muscle cell destruction, necrosis. Crucially, they also look for the absence of something called granulomas.
Granulomas. What are those again?
Think of granulomas as these organized, little walled-off clusters of immune cells. The body forms them in response to certain infections or inflammatory conditions like tuberculosis or, importantly here, sarcoidosis.
So GCM inflammation looks different.
Right. GCM's inflammation is typically more diffuse, more spread out, without forming those neat little clumps or granulomas. Seeing that widespread inflammation without granulomas helps pathologists tell GCM apart from sarcoidosis, which is important because the treatments are different.
But I remember hearing even the biopsy isn't perfect. Is that right? That adds another layer of difficulty.
You're absolutely right. It has limitations. The big one is that GCM can be patchy,
Patchy.
meaning the giant cells and the inflammation might be concentrated in some areas of the heart muscle, but not others. So a single biopsy, taking just a few tiny samples, might just happen to miss the affected spots.
Leading to a false negative.
Exactly. Studies show a single biopsy can miss GCM in maybe up to 32% of cases. So sometimes multiple biopsies are needed over time, or taking samples from different locations to increase the chance of finding it, getting the accuracy up over 90%.
And the biopsy itself isn't risk-free.
No, it's an invasive procedure. The risks are small, but they're real. Things like bleeding, infection, or very rarely perforating the heart wall. Plus, you really need a highly skilled cardiac pathologist to interpret the slides correctly. Distinguishing GCM from other inflammatory heart diseases under the microscope takes expertise. All this contributes to those dangerous delays.
Given how GCM often starts with these vague symptoms, fatigue, maybe a bit of shortness of breath, things many of us might just ignore or blame on being busy, symptoms that are hard to diagnose, it makes you wonder, doesn't it? If you experience persistent, unexplained fatigue or shortness of breath, maybe lasting more than a few days, especially if you're young and generally healthy, how would you react? What would you do?
That's a really tough question. My initial instinct, probably like most people, might be, oh, I'm just run down, need more sleep, maybe catching something.
Right, push through it.
Yeah. But knowing what we know now about GCM, specifically how fast it can move, I think I'd be more inclined to maybe schedule a doctor's appointment sooner rather than later, even if it's just for reassurance. And I'd probably be quite specific, saying, these symptoms aren't normal for me, they're persisting. Could it be something serious?
I lean towards that too. I think I'd be tempted to push for more tests quicker, maybe mention my concern about something aggressive like this, rather than just wait and see. It's that fear of losing precious time. What do you, our listeners, think? Routine checkup or push hard for answers right away? Let us know in the comments.
Yeah, it's a real dilemma because most of the time, thankfully, those symptoms are nothing serious. But for that rare person who does have GCM, waiting, well, it can be fatal. It's navigating that uncertainty.
So once that diagnosis is finally made, the treatment sounds incredibly intense. You described it almost like a high-stakes gamble because the clock is ticking so fast.
It absolutely is. Standard treatments for typical heart failure, like diuretics or ACE inhibitors, they help manage symptoms, but they don't stop the underlying attack. They just aren't enough here.
Because the core problem is the immune system.
Exactly. The problem isn't just weakness. It's an active, destructive immune assault happening right now. So the main strategy is hitting the immune system hard and fast with aggressive immunosuppressive therapy.
Oh, aggressive.
We usually start immediately with high-dose corticosteroids, often given intravenously first, to try and rapidly dampen that inflammation. But steroids alone often aren't enough. The standard approach now is combination therapy.
Meaning adding other drugs.
Yes, adding other powerful immune-suppressing drugs that work in different ways. Things like cyclosporine, azathioprine, mycophenolate, mofetil. Using these combinations has definitely been shown to improve survival compared to just using steroids alone. In very severe or resistant cases, sometimes even more targeted therapies like monoclonal antibodies might be considered.
And these drugs, powerful as they are, must come with serious risks. Suppressing the immune system sounds dangerous.
They do. It's a major trade-off. These are potent medications, and by suppressing the immune system to save the heart, you inevitably lower the body's defenses against infections. This opens the door to potentially severe infections, bacterial, fungal, viral things your body would normally fight off quite easily.
That sounds like walking a tightrope.
It really is. And there are long-term risks, too, like an increased chance of certain cancers developing down the line or potential damage to other organs like the kidneys or liver. It requires extremely careful, close monitoring. We're constantly trying to balance suppressing the GCM effectively while managing these dangerous side effects.
What happens if the heart is already too damaged by the time the diagnosis is made, or if the drugs aren't working quickly enough?
That's when mechanical circulatory support, or MCS, often becomes necessary. If heart function has really crashed despite the medical therapy, these devices can take over.
What kind of devices are we talking about?
Things like intra-aortic balloon pumps, IABP, more durable ventricular assist devices, VADs, or even ECMO, extracorporeal membrane oxygenation, which is essentially a heart-lung bypass machine used short-term. These machines temporarily take over some or all of the heart's pumping function.
Buying time.
Exactly. They act as a bridge. Sometimes it's a bridge to recovery, buying time for the immunosuppressive drugs to hopefully kick in and allow the heart muscle to heal somewhat. More often, unfortunately, it's a bridge to transplantation, keeping the patient alive until a donor heart becomes available.
But these machines have risks too.
Oh, yes. Significant risks, including bleeding, serious infections around the device sites, and the formation of blood clots, which can lead to strokes. They are life-saving interventions, but complex ones.
And ultimately, for many patients where the damage is just too extensive, transplantation is the only remaining hope.
Yes, heart transplantation is often the last resort for GCM patients who have irreversible, severe heart damage. It literally replaces the failing heart and can be truly life-saving, offering a chance at a longer life.
And this is a terrifying aspect of GCM, getting a new heart doesn't necessarily mean the nightmare is over. It can come back.
That's right. It's a devastating reality of this disease. GCM recurrence after transplant is a significant problem. It's reported in somewhere between 12% to maybe 26% of patients who receive a transplant for GCM.
12 to 26%.
Yeah.
That's quite high. And when does it happen? Soon after.
It can happen relatively soon, within weeks or months of the surgery, but it can also happen years later. Cases have been reported returning as late as 8 years post-transplant.
8 years. Why? Why would it attack the new heart?
The fundamental reason is that transplanting the organ, the heart, doesn't reset your underlying immune system abnormality. The same rogue immune response that attacked your original heart can, unfortunately, recognize the new heart as foreign, or perhaps just gets reactivated and targets it too.
Even with immunosuppression.
Even with the lifelong immunosuppression that all transplant patients take to prevent rejection. In fact, sometimes reducing the dose of those immunosuppressants, which might be done cautiously years after transplant, can inadvertently trigger a GCM relapse.
How is recurrence usually detected? Does it feel the same as the first time?
Sometimes, thankfully, it's caught early on routine surveillance biopsies. Transplant patients undergo regular heart biopsies, especially early on, specifically to look for signs of rejection. Sometimes GCM recurrence is picked up incidentally on one of these biopsies before the patient even develops symptoms.
That's lucky in a way.
It is, because it allows for earlier intervention. Other times, unfortunately, it presents just like the original disease with new symptoms of heart failure, like worsening shortness of breath or swelling, or the development of dangerous arrhythmias again.
And how is recurrence managed? More drugs.
Yes, the main approach is to intensify the immunosuppression again, hitting the immune system even harder. This usually involves high doses of corticosteroids again, sometimes adding or increasing the doses of other powerful drugs like cyclosporine or mycophenolate. There isn't one single standard protocol. It tends to be very individualized based on the patient and the severity.
But intensifying that immunosuppression, that brings back all those risks you mentioned earlier, right? Infections, other side effects.
Absolutely. It brings back those significant risks with a vengeance. Severe infections become a major concern. The long-term risk of malignancy might increase further, potential organ toxicity. It's that incredibly difficult balancing act all over again, trying to control the GCM recurrence without causing overwhelming harm from the treatment itself.
So even with a successful transplant, this isn't a disease you ever truly leave behind. The threat remains.
No, unfortunately, the risk of recurrence is always there, casting a shadow. It's a serious threat to long-term survival and quality of life after transplant for GCM patients. It really underscores just how complex these immune-mediated diseases are and how challenging they can be to control completely, even with our best therapies. Early detection of recurrence through that routine monitoring, those biopsies, is absolutely key, but the risk never fully disappears.
Okay, so with a disease this unpredictable, this aggressive, this hard to truly eliminate, can anything at all be done to prevent it in the first place?
Sadly, the difficult truth here is that there are currently no proven strategies to prevent giant cell myocarditis.
None at all.
None that we know of. For most cases, we simply don't know the exact cause. It's considered idiopathic, meaning it just seems to arise spontaneously without a clear known trigger. There are no identified lifestyle factors like diet or exercise, no specific genetic markers that we know of yet, no environmental exposures that we can point to and say avoid this to prevent GCM. It truly seems to strike unpredictably and, as we've said, very rapidly.
So prevention is effectively off the tail right now. What can we do then? Is the focus entirely on early detection and vigilance?
Exactly. That's where our efforts really have to concentrate. Vigilance and early detection. For individuals who already have another known autoimmune condition, remembering that 20% link, being extra aware of any unusual or persistent cardiac symptoms, like unexplained fatigue or shortness of breath, and reporting them to their doctor promptly, that's important. Some guidelines even suggest annual cardiac checks for certain autoimmune patients.
And for the general population.
For everyone, it's about recognizing those early, often vague symptoms, that unusual level of fatigue, the shortness of breath that doesn't quite fit, the swelling, the palpitations, and crucially, understanding how quickly GCM can worsen. If those symptoms are persistent, maybe lasting more than a couple of days without a clear explanation, or especially if you experience severe symptoms like sudden chest pain, fainting, or really significant shortness of breath, don't delay. Seek urgent medical attention. Often, that means going to the emergency room.
And being prepared to advocate for yourself, maybe, if something feels really wrong, but initial tests are inconclusive.
Absolutely. Be persistent. Remember how easily GCM can be misdiagnosed initially as something less serious. If your symptoms aren't improving, or especially if they're getting worse despite some initial treatment for, say, a presumed virus or anxiety, you need to push for more investigation. Ask questions. Could it be something more serious affecting the heart?
And specifically mentioning the possibility of needing that biopsy.
Yes. Advocating for further cardiac testing, potentially including an endomyocardial biopsy if suspicion remains high based on the clinical picture, even if initial non-invasive tests weren't definitive. And remember, because of that patchy nature, even a first biopsy can be negative, so repeat testing might be necessary down the line if things still don't add up.
And then, post-diagnosis, that vigilance has to continue indefinitely.
Lifelong vigilance. Strict adherence to the immunosuppression regimen is absolutely vital. Skipping doses significantly risks recurrence. Taking precautions to avoid infections becomes critical because the immune system is suppressed. And then, as we discussed, lifelong monitoring for potential recurrence, even years after transplant, often involving those regular surveillance biopsies, is essential.
This deep dive into giant cell myocarditis certainly reveals what can only be called a devastating medical horror. It strikes without warning, progresses with terrifying speed, challenges our diagnostic abilities, and can even return to attack a new heart.
It truly highlights the incredible complexity of the human body, particularly the immune system, and frankly, the current limits of our medical understanding when it comes to tackling these diseases where our own protective systems turn against us.
Given the devastating impact of GCM, how it can strike anyone, progress so rapidly, and even return after a transplant, what do you think is the biggest single challenge we face right now in tackling rare, aggressive autoimmune diseases like this one? Is it understanding the trigger? Developing safer treatments? Faster diagnosis? Let us know what you think in the comments.
That's a great question to ponder.
Thank you so much for listening. Please subscribe, and as always, have a nice day or good night, and stay safe.